So let's shift gears a little bit and look at the American Heart Association risk stratification. These are slightly different than ACSM. Once again, these are for clinical populations. So Class A, apparently healthy. Class B, known but stable cardiac heart disease and low risk of complications. And so these are people, again, about 6 Met capacity. And then Class C, moderate to high risk of cardiac failures during exercise. They've got heart failure, they've got other complications, maybe they get arrhythmias. And then Class D, unstable disease. So these are people who are getting chest pain, they're getting lots of really bad arrhythmias, and they have to be restricted from activity. And that's going to be very few people. That's only going to be probably the most senior adults or the people with the most serious heart disease. So once someone has a heart attack, or they go to, or they have a bypass or an angioplasty, who actually goes to cardiac rehab? So typically people who've had chest pain, and they've had ischemia, estimated by their double product, what's called that, their systolic blood pressure times their heart rate. We talked about people taking nitroglycerin, just like the stuff you remember from, Bugs Bunny and Wile E. Coyote. It will dilate the blood vessels in the heart, lessen chest pain. But the problem is people who just have risk factors are not going to be referred to cardiac rehab. That ship sailed probably almost 20 years ago, back when I was a graduate student. Insurance used to pay for preventive cardiac rehab, but that just doesn't happen anymore. Typically, in order to go, you had to have had a heart attack, a myocardial infarction. We talked about that in class, where that piece of heart muscle dies, and so it loses function, and the amount of damage is dependent on the location and size. And so people who have a heart attack are oftentimes referred to cardiac rehab. People who had what's called a CABG, sometimes there's an S on the end, or sometimes it's just a CABG. So it's a bypass. It's exactly what you think a highway bypass goes. So they take a vein, your saphenous vein from your leg or an internal artery, and they make a little bypass around that blockage. If you go to the link section on Blackboard, you can pull up the American Heart Association site, and they've got some very nice animations of myocardial infarction and a bypass. The bypass definitely relieves angina, so it's great at doing that, but you're going to have the big scar, you're going to have the sternum ripped open. So, but especially if people have genetics or they don't really change their lifestyle, the bypasses can close and the arteries can reclog. So a person who's had a bypass may need to go back at 10 years out and have something done. And recently that happened to President Clinton. He had the bypass surgery, then he had to go in and have an angioplasty, and that's what we're talking about next. So the PTCA, coronary angioplasty, usually if the coronary heart disease is not severe, or it's in one or two smaller arteries, if people have large areas with multiple blockages, then they're usually going to have a bypass. So you're going to hear that someone had triple bypass, quadruple bypass, so they had a bypass in 3 different places. So they used a balloon tip catheter. They go in through the femoral artery. They're taking images, the cardiologist, and it's usually done on an outpatient basis or maybe an overnight stay. And if you see if you look on the American Heart site, there are some nice animations of how the plaque is pushed back, and then they can insert a mesh stent to keep that artery open, but it can still reocclude, the stent can collapse. You can develop blockages in other areas than where the stent is. So it's not necessarily a permanent solution. So people really do have to work on their lifestyle. They have to take their medications. They have to exercise. And even still, that may not help them either.